Good evening, ladies and gentlemen. This is Dr. Hiba Barakat, Healthcare Programs Manager at AUC Executive Education. I hope you are all keeping well and staying safe during these testing times. It's an honor to welcome you all to our webinar today, which is amongst our Business Reconfigured Healthcare Track series. You can join our webinars by registering through the Executive Education Facebook page or the Executive Education website. Before we begin our webinar session today, I'd like to share some engagement tips that would help enhance this webinar experience. Please keep your microphones muted so we do not experience any noise distortions. Please do not open your camera or start a video so we maintain a smooth streamlining connection. We have ample time at the end of the session to answer all your questions, so please park all your questions till after the session so they are structured comprehensively and in relation to the entire discussion. During the question session, if you have any questions, please write it in the chat box addressing Hiba Montasir. We want to stick to the time designated to this webinar and wrap up at 8:30 p.m. today. Today's webinar session will be on COVID-19 infection prevention and control, featured by Dr. Nagwa Khamis and Dr. Amal. Dr. Nagwa Khamis is a professor of clinical microbiology at Shams University, head of infection prevention and control department at Children's Cancer Hospital in Egypt, 57357, board member and immediate ex-secretary of International Federation of Infection Control, president of Society of Practitioners of Infection Control of Egypt. We hope you all enjoy today's webinar. Dr. Nagwa, the floor is yours. Kindly unmute yourself, Dr. Nagwa, please. Dr. Yes.
Thank you very much, Dr. Heba, for the introduction. And good evening, dear esteemed colleagues. So this evening, I'm going to give a presentation about COVID-19 infection prevention and control at the global, regional, national, and organizational levels. Before starting, let me declare that all the data in the following presentation is Children's Cancer Hospital of Egypt, 57357 copyright. And let me tell you about our vision, which is to provide a unique worldwide model of cancer-free childhood in which infection prevention and control is a pillar and is an asset. To start with today's presentation, we have to know a few words about this family of corona viruses. They are characterized by being large, which explains why they do not spread by air. And this may explain also their transmission via droplets. And they are envelope viruses. And this explains again why they are sensitive to washing with soap and water, and they are sensitive to all alcohol-based products, 70% alcohol. In this picture, we can explain the transmission of coronaviruses. If we look at this light yellow dots, they represent the droplets carrying the virus. And usually these droplets, we found them if we cough, if we sneeze, or even while talking. We don't see the droplets, but this is just to highlight them. And as we see, once they are released, they are falling down, and few of them, of fine droplets, they could travel a bit and settle on the nearby surface like this window, like this red dots. And if we touch this dots, they represent virtually the viruses. If we touch them and then we use our contaminated hands without hand hygiene, we can catch the infection. That's why a minority of the transmission could be by contact. This screenshot of the CDC website, it dates since 6th of March. And I intended to put it in my presentation to show how and since when we had all this information about corona, how it spreads, the prevention and treatment, what to do if we are sick, the symptoms, and even the stigma with COVID-19. Maybe one single information was a bit confusing for us as infection preventionists was the mode of transmission. CDC wrote it as airborne at the very beginning, while the WHO at the same time, they claimed since the first moment it's a droplet transmission. But again, all this information have been present regarding how to protect ourselves, the frequently asked questions, advices, and so and so. So we had the opportunity to be guided with international guidelines since the very beginning, since early of March. And the WHO had declared the outbreak in China very early, again, on January. As we see here, how this outbreak have been evolved to include nearly all the globe. It started in China, went next to Europe. In Italy, they have been surprised and prepared with the novel corona. And in France, they have been partially prepared. In Germany, they gave the example of good preparedness. And for us, the German experience is considered, and not only for us, it's for all over the world. They consider the best experience with corona is the German experience. And in other countries, they had a status like unwillingness to be prepared. And this was met with the UK, in USA, and in Brazil. In Sweden, they adopted the theory of herd immunity. In Australia and New Zealand, they did a splendid isolation. And till now, yesterday or the day before, Australia had declared that they will close the border till the beginning of 2021. So they will stay in isolation till the end of this year. However, for our continent, Africa, the outcome is still unknown. This is the latest update. This is yesterday data about the pandemic, which was confirmed by the WHO by the 12th of March. And as we see, this is the curve of Europe. I will comment of Europe first because we have to see the width, the maximum width of the curve. It was in March. So for the countries in Europe, especially Western Europe, they have all of their cases during March, over March, April, and they started to decline by May, and now they are more or less in safe position. While for the state, we will find the maximum width is nowadays, currently on June, or during the immediate past month. And US, they claim that they have a decline phase, but it didn't stay for a long time. And again, they have a surge again, and now they are suffering from an again increase of cases. This is the Eastern Mediterranean with this green curve, and this is our region, Eastern Mediterranean. We had most of the cases during May and June, and this purple area of the curve is for South Asia, and still they are a bit similar to our curve. And the blue one is for Africa, and we have most of the cases again in May and June, although we didn't reach high number of cases like in the States or in Europe. So this is just to compare a bit all the continents, all the regions over the globe regarding the spread and the epidemic curve of COVID-19. The science have moved much with this pandemic. So nowadays we see new clinical syndromes have been explained, like the Kawasaki syndrome, and this is a fatal condition. We found the first data about the vaccine trials and the launch of vaccines, just to deliver some positive data about this infection, which is more or less for all the globe like a nightmare. We have first results from randomized controlled drug studies. Because we are very worried about the treatment of this emerging infectious disease. So far, all what we are trying are just trials of treatment. We are not sure about any of these drugs. There is so far no specific antiviral treatment for this novel virus. We are encouraging publications on monoclonal neutralizing antibodies, and this is also is published in order to give a way for the medical teams for the management and for the treatment. We heard about the treatment with the plasma for the recovered and the treated cases. But unfortunately, also we have also seen the first science scandal with fake data published in highly ranked journals. We heard about one of the journals publishing data about COVID-19 treatment using the anti-malarial drugs, and it was a publication which was launched or released while not making sure of the data. We gathered data and we delivered them as if it is something evidence-based, and it was found that it was fake data. Currently, we published this pyramid about the safe countries, and they have been dividing all the countries into 4 levels. On the top of the first tier was Switzerland, and by the way, yesterday Switzerland declared again 137 cases with 2 deaths. For our beloved country, we are in the 3rd tier, but let me say that for now, no, not a single country, nobody can tell that we are totally safe about this COVID-19, so long as the pandemic is still there. If we are going to give some examples about the regional level of managing this corona, we will find one of our neighbors in the United Arab Emirates, in United Arab Emirates country. They started their measures very early. They started on the 23rd of January. And this helped much to minimize the cases, provided we all know that Dubai is one of the international hubs regarding the traveling, the diversity of populations. However, they did their plans, they did the case definition very early in reference to WHO guidelines, because when we have all this data, we are helped much to manage our measures of infection prevention and control. And our second neighbor was the Kingdom of Saudi Arabia. They launched their guidelines. They launched so many flyers, posters, and we in our country in Egypt, we used their documents because we needed this customized data in our region to use them to start to manage the infection prevention and control, because at that time we have still the time for prevention before having the level of community spread. If we will talk about the national level, we should start by China, of course, because it was the first focus where the first case was detected in Wuhan city, and it was on December 2019, and maybe before. And at that time, they declared that the infection was linked to a live animal market, specifically the bats. And they denied at that time that the infection would be transmitted from human to human. But lately, when the community spread occurred, confirmed human-to-human transmission. Another example of the national level is France. A kind of, or one example from Western Europe. In France, they started their management and they launched their guidelines by the 20th of February, and it was considered relatively late. That's why to work with this document, they took some time, and they couldn't prevent it very early like Emirates, and they have so many cases, and they have their peak in the mid of March. In France, they usually do their guidelines very structured, very detailed, so you can find anything or any information about the infection prevention control or the management or the type of disinfectants or the supply chain, and everything was there. At the national level in Egypt, this is the epidemic curve in Egypt. As we see here, I don't know if you can consider this a peak level, because to my knowledge, the peak should be like a point, the highest point. Here we found it more or less up and down, but again, this is the highest or the maximum density of the curve during May and June. And this is the curve of that. And the first case declared in Egypt was by mid-February. We had our national plan launched on March 2020, and myself, I consider it a bit belated because we have been searching for documents to work with it, a national one, because even if we are going to refer to international documents, international guidelines like the WHO, all the countries are following by default. But again, we need our national plan, our national guidelines, and our regulations. But if we have been a bit late for launching our plan, now we are updating our guidelines and our plans regularly. And this is the well-structured index of our latest version of Egyptian guidelines of managing corona, SARS-CoV-2 or COVID-19. And so many posters, so many flyers have been delivered as well, showing many topics regarding the disinfection, regarding the symptoms, the transmission, and how to protect ourselves. On daily basis, we have the newly tested cases with the mortalities, with the number of recovered cases. But if we see from the 27th of February to the 8th of March, the cases have been increased 48 times. On the 27th of February, we had just one case, which was declared on the 14th. And we stayed with this single case for about 2 weeks. And then the cases have been multiplied up to 48. And this was the start of saying that the infection is spreading over the community. To talk about any global threatening infectious disease, we have to have some knowledge about the so-called risk communication, and to know that what should have been done to avoid rumors and loss of trust. And to talk about risk communication, we have to know that it is a dynamic and interactive process that involves change between different groups. The exchange of information about the health risk is going and forth on and back among individuals and institutions. So I would like to explain a bit this picture that we have whenever we face a risk, we have to explain everything about this risk, okay? And the explanation means that to address the knowledge, to assign people who are going to handle this risk, to let them know everything about it, how to protect themselves, how to manage it, because they are going to search for this knowledge. And when I deliver the proper knowledge in the proper time at the level of the risk, I will save time. I will save this situation of working with the crisis rather than the risk. So when we work always at the risk level, it's much, much better to wait till it had become a crisis. And this is just the risk management cycle, in which the risk communication, as we see, is in the heart of this risk management cycle. It starts by identifying the hazard, then to assess the risk, to develop a policy, to implement it, and to evaluate it. Okay, so we have to go through all of these steps to fulfill the risk management cycle. And about the risk communication, I'm going to communicate and to give information about the risk. Four theories or four theoretical models have been identified by Covello et al. In 2001. We have four models. The first one is about the risk perception, how people are perceiving the risk, and how can we shape the perception of the risk so that we direct the knowledge in the proper way, and people, the assigned people, the medical team specifically, wouldn't misperceive the risk. Then the other model is the mental noise. If we communicate properly about the risk, we wouldn't leave any opportunity to have this mental noise that goes with the person into misperception. And to do this, we have to do like intimate or deep interviews, in-depth interviews, and to repeat the knowledge. We have to repeat the knowledge because repetition always reinforces the knowledge. The third model is the negative dominance, and this is a good example of population like ours that have so many things relying on emotions. And when we are facing a risk, we always feel like we are going to die. There is this kind of negativity that overwhelms and will be on the expense of any positive outcome. And finally, the model of trust determination. When we work by communicating the risk, we give them the proper knowledge in the proper time, and we don't leave the field for any rumors. And being transparent and communicating and accepting the discussion, this will build up the trust. And this is very important when we talk at the level of risk. Why we need to risk communication and why we need to apply these models? Because we are no more living in each one in his country. We are living in the era of uncertainty, the rapid change, and the globalization. There are no barriers between countries, and communicable diseases will always be there. And we cannot prevent the transmission, and the transmission might go so fast, like this SARS-CoV-2. So it's very important to have this model and guidelines for effective risk communication to be clear for everybody. And the emerging infectious disease have been present and will still be there all the time so long as we are living on this globe. At the hospital level, before starting anything about this, I have to introduce my heroes, my team in the Cancer Children Hospital of Egypt, with my team leader, my director of nurses, my supervisor of nurses. I have 2 lab chemists and 9 IPC coordinators. For the preparedness and the management of any risk management plan, we have to identify first the risk and to communicate it, as I explained in the previous few slides, and to apply the preventive measures, to do the patient flow from the screening till the management, to put down the isolation areas map, to provide the needed personal protective equipment, and to teach the healthcare workers and others in the healthcare organization how to use them properly. And this will go via awareness about any infectious disease like COVID-19. And usually we do it in the form of campaign. We started by a preparedness policy, and we have been lucky because while having the JCI review last year, 2019, on February, we have been requested to have this policy or this program in our manual of IPC. This is a policy for management of emerging global threatening infectious disease. So when we had this COVID-19, we just customized it to fit with the new emerged infection. We did isolation map in relation to location and in relation to patient condition. And I mean by this, for the suspect cases, they are confined to specific areas in the hospital, and for the confirmed, they are put in cohort in another area for isolation. We did a campaign to provide the knowledge about this COVID-19 or the SARS-CoV-2, and it was, we ran this campaign on March 2020, and as we are going to, I'm going to present for you, since March, we have every month an activity in the hospital supporting the training and the on-job training specifically, and to reinforce the knowledge about COVID-19. Whenever we do any campaign, we start by giving lectures, on-job training, and then we assess the knowledge by auditing. And this is a screenshot of the auditing tool. We continued by educating healthcare workers in the hospital, doctors, nurses, pharmacists, housekeepers, about personal protective equipment, and we did on-job training about the donning and the doffing of the PPEs, and this was on April. We have videos emitted on the screens all over the hospital, even the patient's room. And this video was about the PPE donning and doffing, and another one about what to do and what not to do regarding infection prevention and control, like the cough etiquette and how to say hello to someone not approaching. And on May, we launched a program, we called it Championship Program. And this was like assessment of knowledge among healthcare workers. And for this, we prepared a set of questions in the form of cards, as you see. And then we go in the department, we start asking the questions, and then we do scoring at the department level. And the highest, for the highest score, the cup will go for the highest score. And as you see here, there is the key, and the key is for the second place. And it is like a motivation for the department who went for the second place to be to do better and to go for the first place next time. We got ready with Plan C, and for this we started to reprocess the N95 mask, and we did for it a policy. And we did it after confirming that the FDA have approved this guidelines. And we did the universal source control at our gates. We take the temperature for all the hospital staff coming into the hospital, and the patient, the visitors, and everybody entering the hospital. And we provide for everyone a surgical mask. We launched our last policy about tolerance, and we mean by tolerance is to survive, to work while Corona is over there. And the purpose for this policy was to ensure the sustainability of the infection prevention and control measures among patients, healthcare workers, and others during COVID-19 pandemic. And we were keen to make sure that the hospital is providing the best care for all the working staff, and the environment is the hospital is very safe for everybody to work and to stay, and to take a home message to take care of ourselves, to stick to the wear of the mask, the face mask, the surgical one, to avoid any overcrowding, to keep the social distancing, and to stick to the hand hygiene all the time. For sure, for everybody, we face this comics during our work since we have this SARS-CoV-2 or COVID-19. Let's have some of them to end my presentation this evening. And it is phase-based. So in the first phase, we have preparing healthcare workers to properly wear the personal protective equipment. So they have been very, very meticulous to wear all the PPEs, and even for their toes, they put on gloves. And for phase 2, we were searching for a proper treatment for COVID-19, and all of us have heard about the declaration or the statement said by Donald Trump, the president of the US, when he said, why not to use the disinfectant for the treatment of corona. And finally, for the tolerance phase, we are ensuring the physical distancing. And for this, we say that the new model of shoes respecting the social distance had arrived. As we see, this might measure the 1.5 meters we insisted to have while we are in public. So about the lessons learned, this is the globe saying thank you to coronavirus. Thank you for the pause, for the break I took, because everybody have been confined at home. But Corona replied, do you think they did understand? They did learn the lesson. It's very malignant, this Corona. It's not easy. Finally, I thank all infection preventionists. Really, you are superheroes. You are the heroes of this time. Thank you very much.
Thank you, Dr. Nagwa, for such an informative and pleasant presentation. Now, our next speaker is Professor Amal Sayed. She's a professor of clinical and chemical pathology, Kasr Aini School of Medicine, Cairo University. She's a deputy manager for environmental affairs and infection control director of Cairo University Hospitals. Professor Amal, the floor is yours.
Good evening. Today I will present our experience Cairo University Hospitals as regard COVID-19 in infection prevention control. First, thanks to God who helped us to take this responsibility and saved all of us. Thanks to those all supporting our and successing our infection control program. President of Cairo University, Professor Dr. Muhammad Osman Al-Fush, Dean of Faculty of Medicine, Professor Dr. Hala Salah Al-Din, Executive Director of the hospital, Professor Dr. Ahmed Taha, really all hospital managers, all our hospital managers and their heroes, infection prevention support teams. And finally, thanks to AUC organizing teams. Starting now, just a hint, the infection prevention control program structure of our Cairo University hospitals. We have many hospitals with different specialization. Infection prevention control organization structure presented with the hierarchy for infection prevention control, which flows in separate committees in each hospital, presented by the each hospital manager and infection prevention control team. Each team have a dedicated trained infection prevention doctors in each team, and minimum ratio of one full nurse infection preventionist per 250 beds. However, in some hospitals where there is more beds of ICU, we increase the ratio to be one nurse per 100 beds. The role of our hospital infection prevention control tried and adopted guideline at the facility level. This guideline should be evidence-based and reference national and international, and should be adapted to the local conditions, which is very important. The primary goal of the infection control in different facilities of our facilities to protect the patient, protect healthcare workers, protect the visitors and others in the healthcare environment, and important to achieve this protection in most cost-effective manner within the constraints of the available resources. Infection prevention goal in outbreak preparedness, the aim is to reduce transmission of healthcare associated infection, enhance the safety of the staff, patients, and the visitors, enhance the ability of the health facility to respond to the outbreak, and lastly, reduce the risk of the hospital itself to be amplifying the problem of outbreaks. Really, we're starting preparedness for infection prevention control in context of COVID-19 from January. We started with risk communications for healthcare workers, increased our supplies chain from personal protective equipment, hand hygiene equipment, environmental cleaning, and disinfectant equipment, and put the policy for rational use of personal protective equipment and considered during shortage, and lastly, enhanced training and education to the highest level. For risk communication or best practice, we infused risk communications as a policy decision, treat risk communications as a process, involve all the stakeholders in risk communication, present risk communication message with honesty, and last be open and ready to all the health stakeholders all the time, nearly 24 hours, 7 till now. Risk communication package for healthcare workers, there is a simplified message and reminders based on WHO CDC technical guide on infection prevention control. This package contains 8 products. The 8 products of risk communication for the healthcare workers, our healthcare workers, for preparing for the COVID-19 as the healthcare facility, managing the patients suspected or confirmed COVID-19, protecting our healthcare workers and personal protective equipment supply and used according to healthcare activities, informing our healthcare workers how to communicate with patients suspected or confirmed COVID-19, how our healthcare workers coping with stress, and information sheet for COVID-19 provided for patients and visitors, and 5 comments of hand hygiene to be applicable on staff and training and meeting. Our message for healthcare workers, you must protecting yourself, protecting your patients, and protecting your family and the community. This is a hierarchy for infection prevention control in pandemic. The most effective is elimination, physical removal of the hazard, followed by engineering control as lead people from the hazard. Then administrative control change the way the people work. And the least effective is protect the worker with personal protective equipment. Infection prevention control strategies to prevent and limit transmission of COVID-19, early recognition and source of control in the form of triaging, applying standard precautions, transmission-based precautions, administrative control, and lastly, engineering control, measures. We started with the following. Triaging stations as the entrance of emergency unit and the outpatient clinic of all hospitals prior to waiting area will be prepared to screen patients with COVID symptoms like fever, cough, shortness of breath, the new symptoms of loss of smell and loss of taste. This limited potential infection throughout the healthcare facility. At a triage screening area, equipment provided where screening questionnaires, algorithm for triaging, hand hygiene group and posters, personal protective equipment, infrared thermometer, waste bins, and the access to cleaning and disinfections. At triage and screening area, ensure adequate space between the staff and the patients. Maintain one-way flow for patients and for the staff, and a clear signage for symptoms and direction. Some photos of our triaging area in different hospitals. This is triage area at Cairo University Children's Hospital. We see algorithm for the triaging, hand hygiene product, our healthcare workers with complete protective equipment, trying to keep distance between the healthcare workers and the patients. Another triaging area in emergency hospital, also our healthcare workers with the complete personal protective equipment, trying to keep the distance between the healthcare workers and the patients. This is our emergency hospital with hospital manager inspecting the hospital triaging and healthcare worker commitment to personal protective equipment, and in this photo, actually he ordered the nurse to dress the patients the mask. triaging area of gynecology and obstetric hospital, segregating pregnant women into non-COVID, suspected, and COVID patients. Another triaging area for oncology and nuclear medicine center. We applying standard precautions and transmission-based precautions. As regards the standard precautions, the precaution applied to all patients at all time, regardless of suspected or confirmed status of the patients, and must be associated with risk assessment. According, we select which PPE will be wear and perform hand hygiene according to 5 points of WHO. Standard precautions elements including hand hygiene, respiratory hygiene, personal protective equipment, safe injection, safe handling of patient equipment, environmental cleaning, safe handling of and cleaning of soiled linen, and waste management. Hand hygiene, our hand is the main tool of work as the healthcare workers, and it is the main chain of transmission of infection. So the best way to prevent the spread of germ is to clean hand. Based on this standard, we applying hand hygiene dispenser distributed everywhere in our hospitals and training on hand hygiene. Another hospital is hand hygiene dispenser distributed everywhere in the world. A small hint is that a small amount of hand hygiene in this bottle is about the size for compliance for hand hygiene. Another type of hand hygiene is washing the hand with soap and water, and this is a hand washing stations at one of our hospitals, Cairo University Specialized Pediatric Hospital, with the water and soap and tissues for drying the hand after washing. Hand hygiene training at one of our hospitals, Cairo University Specialized Pediatric Hospital. Personal protective equipment, our principle for personal protective equipment instruction to our healthcare workers that hand must be cleaned before and after wearing PPEs. PPEs should be available where and when indicated and in correct size, selected according to risk assessment or transmission-based assessment. We just put on PPE just before entering the patient room. PPE always removed immediately after completing the task or leaving the patient care area. Never reuse disposable PPE, and if we use reusable personal protective equipment, must be cleaned and disinfected between patients. Principle of using PPE also, PPE must be changed immediately if it becomes contaminated or jammed. A very important note, PPE shouldn't be adjusted or touched during patient care. Face shouldn't be touched while wearing PPE. If there is no concern or breach of this practice, healthcare workers are instructed to leave the patient's care area when safe to do that and probably remove these PPEs. PPE should be removed carefully to avoid contamination from dirtiest to cleanest. We update guidance on rational use of PPEs, optimizing the PPE supply chain, use PPE appropriately, and minimizing personal protective equipment need. Who needs PPE? The patients for source control and the healthcare workers for protection. How are we minimizing the need of PPE? The following we will consider to minimize the need for our personal protective equipment. Telemedicine will consider to evaluate suspected cases, minimizing their need to visit the facility. Secondary physical barriers were implemented like glass and plastic screen with windows, where patients first present like triaging area or pharmacy. Numbers of healthcare workers entering the patient room were limited. Activities are planned to avoid multiple exits and entries to the patient room, and lastly, working in a bundle were considered like check vital signs when administering medication to combine the issues with each other to limit the number of entries and exits to the patient room. Physical distance. Ensuring physical distance inside the facility's room, healthcare workers were scheduled in teams that work alternately to prevent crowding. Number of visitors into the facility were restricted, even inhabited. Physical distance for staff group activity were ensured. Any group and social gathering were prevented, and for cafeteria level, we closed the cafeteria and the dining hall, and available only takeaway meals. Environmental cleaning and disinfections, as contaminated environmental surfaces play a role in transmission of the virus, must be cleaned and disinfected. Environmental cleaning, disinfection frequency increased in all our hospitals and in all our departments. Cleaning must be cleaning with detergent and water must be proceeded the disinfections. In our hospital, sodium hypochlorite in concentration of 1,000 part per million and ethanol 70% are approved. Coronavirus has surface stability with different time. Time depends on the material of the surface, viral load of the particle, or even temperature and humidity. Particular attention should be paid to the high touch surface in cleaning and disinfection. There is a mini part which is high touch and must be cleaned routinely and frequently, like light switches, bed rail, door handle, tables, mobile parts, sink, which we must be cleaned and disinfected frequently. This photo representing deep cleaning and disinfection of one of our ward after patient confirmed with COVID-19 were transported to isolation hospital, cleaning from up and down, from cleaning surfaces in one direction, special attention to bed rails, light switches, mobile parts. Continue cleaning for this department, then followed by disinfections, and now the department became ready to admit another new patients. Another precautions besides the standard precautions, conduct and appropriate precautions, airborne when aerosol generating procedures were done. These precaution, transmission-based precautions should continue until the patient is asymptomatic. Suspected or confirmed patients must be avoided to be transported to another place. If transportation is important, patients wear masks and the receiving department must be informed at least 30 minutes before transportation of the patient. Equipment used for the patient should be single use when possible and dedicated to the patients and disinfected between use. The frequent cleaning of the environment is crucial. Administrative control changes the way the people work in the form of provision of adequate training of healthcare workers, updating to the policy for isolation, isolating suspected cases, suspected confirmed cases, suspected and confirmed cases should be separated, labeling the door of the isolation, restricting the number of persons entering the patient's room. All of this must be approved. For education and training, the three categories of our human resources that subjected to training, infection control specialists, all healthcare workers, other personnel supports the health services delivery. This is a staff training. This is a photo. This photo is for training of our staff in context of COVID-19 with all full commitment to physical distance. We see that, and wearing of all the staff present attending the training for their mask. Another training for doctors before joining work in isolation hospital is full commitment to physical distance and wearing this mask. This training is on donning and doffing for PPE mainly before joining work in isolation hospital. Another training in another hospital, Cairo University Children's Hospital, for hand hygiene, personal protective equipment, and training for nasopharyngeal swabs, pediatric nasopharyngeal swab. Another training for pediatric nasopharyngeal swabbing, continues the same training in the same hospital. Training on hand hygiene in another Cairo University specialized pediatric hospital, keeping the space and wearing the mask. Engineering control, starting from the emergencies of COVID-19 and the pandemic. Each hospital manager, in cooperation with the infection prevention control team, allocated rooms for isolation of suspected cases and confirmed cases. This room expanded to be complete ward in some hospital in community spread existing. Bed occupancy should be one patient for one bed. Adequate spacing between patients is important. Good ventilation is provided. Some photos of our isolation room. This isolation room is an active isolation room, well prepared, allocated for suspected confirmed and confirmed pediatric patients. Cairo University Specialized Pediatric Hospital. The room is attached with empty room with storage area and hygiene stations area. Ventilations, natural ventilation should be assured for the waiting area, triaging area, mild and moderate work. 4. Critical work, hybrid ventilation should be assured. Top-down airflow moving from clean to dirty, negative pressure is assured when aerosol generating procedure is performed. Air conditioning and the spread of coronavirus. Air conditioning may spread virus particles through circulating infectious particles, especially problematic if there is crowding or small enclosed spaces. Normally, many people produce large particles like that. These particles tend to fall near the person. Another particle may be intermediate and fall a little further, up to 6 feet away, stressing the importance of maintaining 6 feet or 2 meters between personnel. But there are small, very small particles that can stay drift in the air and causing aerosol inhalation. How air conditions work? Air conditions work to keep space cool by removing the humidity from the air, as water vapor can hold air. Moisture also, this moisture which the air conditions removing, wetting the particle, the viral particle or viral droplet, making it to fall down. If we remove the water vapor, remove the cool air at the time where air conditions is warm, infectious particles become lighter and longer than they would outside in another species. So we always said, opening up the windows is easy and cheap. One of the most important solution increasing ventilation and is ventilation and filtration. Ventilation is increased by mixing inside air with the outside air, with outside fresh air. HVAC equipment at hospital and other healthcare facility making the design provide 100% outside air, fresh air for ventilations. Especially, very important note, if central ventilation system remove and circulate air to different rooms, it used to be recommended to turn off the air conditions. Air conditioning system mixes some of the extracted air with some of fresh air from the outside, not to be discontinued. Fan. We choose fan based on what we want the fan to do, either cool temperature or either directionality for the air. 4. Floor fan, and for table fan, it direct air. For ceiling fan, it cool and mix air. For window fan, it exhausts the air. Direction of air, it must move from the healthcare workers to the patients. The most effective place for fan is to be inside or beside the window. Some of infection prevention control practice in essential sources like dialysis unit of our hospital were taken. In this unit, we are taking self and active-based monitoring of the staff for early pickup of infected staff, organized shift duties of healthcare workers, patient awareness in reporting symptoms. This is some photo of the dialysis unit, isolated room for suspected cases. In the room of the dialysis or the unit of the dialysis, patients wearing the mask and healthcare workers with complete PPE, distance between the beds. Essential infection prevention control in essential surfaces like labor room or pregnant women screened in the triaging area according to exposure to people with COVID-19, symptoms of COVID-19, immunocompromised status. Elective obstetric procedures like cervical circulation and cesarean scheduled to be operating at the end of the day. Non-elective procedures are carried out in another obstetric theater and giving a lot of good times to cleaning and disinfections. Number of staff in the operating theater kept to the minimum and all wearing appropriate PPE. What about the newborn? The mother who has confirmed COVID-19 or is suspected was instructed to put on a face mask and practice hand hygiene before each feeding or other close contact with their newborn. Designated surgical room for surgery for suspected and confirmed pregnant woman to be COVID or suspected COVID. Ensures staff and safe surgeons is safe when doing surgery. If no general anesthesia, patient was continuing to wear the mask. If general anesthesia used, HEPA filter was placed between the wipes of the breathing circuit and the endotracheal tube. Quality Kasr team getting ready to work on a COVID-19 case with complete protections. Another sessions of chemotherapy session at the Center of Oncology and Nuclear Medicine, healthcare workers with complete PPE, patients adherent for wearing his mask and spacing between the sessions. Contact of tracing, contact is the individual get contacts with a confirmed case of COVID for at least 15 minutes within 2 meters for 2 days before the illness. If the confirmed case is asymptomatic, then maybe 2 days before sampling, positive sampling. Asymptomatic contact were quarantined and tested at day 5 or day 14. Symptomatic healthcare workers tested once symptoms appear. Both symptomatic and asymptomatic either isolated or quarantined. Contactors, tracing, and the healthcare worker waiting for testing at Cairo University Children's Hospital. COVID-19 clinic, an area of our Pathology outpatient clinic, was set aside for COVID-19 suspected and confirmed cases. At the clinic, the patient subjected to measurement of temperature, pulse oximeters, weight, nasopharyngeal swabing for PCR, complete blood picture, and CRP, D-dimers, liver functions, kidney function, serum creatine, and CT imaging. The clinic served daily from 250 to 300 cases from Cairo University staff members, employees, and their families. All test results and CT reports are ready within 24 hours, assessed by COVID evaluation team. Cases assessed into mild, moderate, severe. Mild cases advised to be home isolation if the home are not accepted for any reasons or circumstances regarding the patient isolated at Cairo University Student Housing Building and followed by follow-up team of our staff. This is Cairo University guides on dealing with with the new coronavirus and caring and how to caring with home isolation healthcare workers. Some photos of our outpatient COVID clinic with ventilated waiting area with complete adherence to physical distance and adherence of all the waiting patients for wearing their mask. Inside the clinic, different stations with physical distance, adherence of our healthcare workers to complete personal protective equipment. CT of the outpatient COVID clinic for initial diagnosis, follow-up of suspected and confirmed cases. Patient isolation, mild patient for home isolations, while moderate and severe cases isolated in isolation hospital. We have 2 isolation hospitals, French and internal medicine isolation hospital. Patients in isolation hospital followed by their staff of the hospital. Patient in Cairo University Student Housing Building followed by staff scheduled in the bed. Patient in home isolation followed by follow-up team of our staff. Healthcare workers working in isolation hospital were subjected to nasopharyngeal swabing for PCR before joining work in the isolation hospital, training IPC standard precautions and transmission-based precaution, especially during the undoffing of PPE, first day awareness inside the isolation hospital for all the procedures and all work pathway, nasopharyngeal swabbing for COVID-19 PCR before they leaving the isolation hospital. Some photo of our isolation hospital. This is a French isolation hospital. Internal medicine isolation hospital after renovation to adapt standard for isolation. Inside the hospital, different department and different floor. Isolation room and CT in the hospital for diagnosis and follow-up of the patients inside the hospital. Lastly, our message to all our employees were notified to prevent transmission to their families at workspace. Avoid carrying accessories to workspace. Pens to keep in lockers at workplace, not to be carried at home. To carry to home. Thoroughly wash hand before leaving workspaces. Reaching home, must change clothes and wash them. Minimizing physical contact with family members. Wash hands frequently. And thank you.
Thank you, Dr. Amal, for such an informative session. Now it's time to receive and answer your questions. Kindly be reminded that you can write down your questions in the chat box addressing Hiba Muntasir. Our first question will be for Dr. Nagwa. How frequent we have to replace N95?
We did the policy to use it during one shift. We can use it several times, and each time it would be kept clean, and it's a requisite to be clean all the time. This is to use it for a prolonged time, but to reprocess it, what we did in our hospital is to do it twice for the same healthcare worker. And the method was for example, for a nurse or a doctor, they put their initials, for example, and the initial of the department, and then they put the N95 in a plastic bag to be collected, and then would be processed in the CSSD in our gas plasma equipment, because it was recommended by the 3M company and the FDA approval to reprocess it in a low temperature sterilizer. So we can use it several times during the shift and to keep it all the time in a clean plastic bag, or even, yeah, it's a plastic bag. And then we transfer it to the CSSD by the end of the shift to be reprocessed.
So the next question will be for Dr. Amal.
Yes, Dr. Heba.
Yes. Do you think that we reached the highest point of cases or not yet?
Egypt or our hospitals?
In Egypt.
The highest number of cases in hospitals or in national?
National, on national level, Dr. Amal, do we reach the highest level of cases, the peak of COVID-19 in Egypt or not yet?
I think we reached it. I think we reached it starting from May. We're starting increasing in the number of cases. Now number of cases is increased, but I noticed that the cases were mild, milder than the previous attacks of the disease. But we reached the biggest level of the biggest level, the peak of the number of the patients.
Thank you, Dr. Amal. What about Dr. Nagma? Dr. Nagwa, how do you see this?
Yeah, I had a slide about this, the epidemic curve in Egypt, and it was shown that it wasn't a true peak. It was a bit blunt. We reached a highest level, but we had it like a blunt peak, a rounded one. And still numbers are wavy. But if we look at the density of the curve, it was mostly during May and June. And this coincides well after our holy month of Ramadan, because we have been all together all the time without respecting social distancing. And at that time, the wear of the mask was not compulsory. And then the community spread had occurred, and so many cases have been recorded. But later, we all, by our professional sense, feel the decline of the cases. Maybe it is not well shown in the curve, but we feel it in our hospitals. We don't have cases as frequent as during last May or June.
Okay. Dr. Amal, what are the main challenges you faced during COVID-19 pandemic since March till now? What are the main challenges you faced?
In the beginning, the main challenges is cooperation with our managers, our hospital managers, and our teams, followed by the supply chains. From the starting of the crisis, we're trying to increase our supply chain, and the success in doing that. We are till now consuming the previous storage of our personal protective equipment, the previous storage of our hand hygiene product, environmental cleaning product, good communications with all our hospital managers, very good communications, and our teams.
Thank you, Dr. Amal. Dr. Nagwa, during nasal swab, will we need N95 or surgical mask?
N95.
Which concentration of H2O2 can be used as COVID-19 disinfectant?
The regular one. Myself, I do recommend the hydrogen peroxide stabilized with silver nitrate at a concentration less than 3%, because otherwise, if it is used at a higher concentration, it would be corrosive. And at this level, it could be effective as disinfectant and could be safe for the environment, surfaces, and people.
Thank you, Dr. Nagwa. Dr. Amal, how
Yes.
can we disinfect fruits and vegetables?
Disinfect what?
Fruits and vegetables.
Fruits and
and-
vegetables.
Yes.
Disinfect fruit and disinfect. I prefer good cleaning rather than disinfection, but we can use disinfectant like very light dilutions of sodium hypochlorite, especially for vegetables and food, or for fooding. Sometimes at home, if we want to do that, we can do some of salt or some of vinegar, either one of these.
Okay. Thank you, Dr. Amal. Dr. Nagwa, what is the best ventilation way in this very hot atmosphere? No way to depend on natural ventilation in temperature up to 50 sometimes.
Let's say that the issue of air conditioning and its role in transmitting the coronavirus is still questionable. There is a big question mark about this because what is settled, and we know in virology that coronaviruses are large viruses, so they are usually they don't transmit via air. Even without the droplet particles, they cannot travel in the air like other smaller viruses. So I believe that when we set our air conditioning system, we usually have the input of the air, the ceiling, and then the suction maybe in one of the walls. If we do positioning of the patient to let him a bit away from the suction, so if he is going to cough or sneeze, he will be away from the suction part. And again, if we can provide our air conditioning central one with HEPA filters, they might help a lot in purifying the air going outside the room, the isolation room. And again, we necessitate a negative pressure room if possible, with anti-room for the donning and doffing of PPEs. And apart from this, my opinion, and what I'm sure about is there is no problem to put on the AC. It is just the proper positioning of the patient to let him to be away from the suction port of the air conditioning. And if we are setting split units in the department or in the isolation ward, this may be a bit easier because we can remove the filter and to wash it very good with water and soap, and then to do like a decontamination with hydrogen peroxide, and then to put it again. And we do this as frequent as we can during the week. It's the best to do it daily, but if we can't, we can do it twice per week, for example. And this is an experience. I did it in practice.
Thank you, Dr. Nagwa. Dr. Amal, please.
Yes.
How do you think about cotton masks? How to clean it and reuse it? What's your opinion about cotton?
Sorry, Dr. Heba, I don't hear the question.
What is your opinion about cotton masks and how to clean it and reuse it?
As regards cotton mask in the community, it's okay. We can approve to be used in the community settings where there is crowdings. But in the healthcare facility, we're refusing to use cotton masks. Any healthcare workers, any worker, any employee inside the healthcare facility must wear the surgical mask or the medical mask. Cotton mask to be wear by the personnel in the community has some restriction also, as if it is contact with a patient's asymptomatic patients, and these patients talk or speak or coughing or sneezing, this cotton mask will not protect the wearer. So it is preferable to use the surgical mask or medical mask inside the healthcare facility for all the people, for all the personnel once enter the healthcare facility wearing the surgical mask. On the community, we can assess the conditions, where it will be in crowdings, will be in place, maybe suspected cases appeared. In that case, surgical mask or medical mask is preferred. As regard the cleaning of the cotton mask, it's cleaning. It is tissue water and cleaning with water and maybe disinfectant with the heat. In the cycle of the washing machine, there is a temperature will reach to 70, 75. This degree of temperature disinfects the tissues, or add some of our disinfectant like sodium hypochlorite, chlor in washing machine.
Thank you, Dr. Amal. Dr. Nagwa, what is the right way to deal with our building elevators regarding as they are closed areas?
For sure, we are going to clean them and disinfect them very frequent. And in our hospital, we modified in our preparedness policy, we modified the section of cleaning and decontamination. We use the same products that we are using, but we increased the frequency of use. So we were doing the decontamination of the elevators like every 2 hours. And again, we restricted the number of people entering the elevator to be not more than 4 persons. And we try to direct them not to look to each other, to look to the wall of the elevator. But again, we have a little problem because we are a children's hospital. So most of the children are coming with their chariot or stroller. And this usually you put it in the middle of the elevator. And at this time, we restrict the number to just 2 persons in addition to the child and the relative, and to be away from each other. Each one would be close to one of the walls of the elevator. And like this, we can manage this part.
Dr. Nagwa, again, for the first question that we asked about the air condition, which is better, central air condition, split, or window air conditions?
No, the window one is the least safe. But the split unit, because I'm not an engineer, but I can imagine that with the split unit, you have the internal part of the air conditioning system that is, you can handle, you can decontaminate without touching the part with the processor. So the window one, I believe, is not a proper one for a place for isolation of infectious disease. But with the split unit, we are trying to adapt. And again, the best is the central with HEPA filters.
Thank you, Dr. Nagwa. Dr. Amal,
Yes.
if only the ceiling fans are available, should be used or not during patient examination or in between patients in outpatient clinics? If only fans are available.
Can be used, but assured there is no crowdings and all the windows and doors are open. If windows, doors are closed and there is crowdings, never turn on fan, ceiling fan. The best form of fan to be used in these situations is the fan inside or beside window to direct the air away from the healthcare workers to the patients, not the opposite.
Okay, another question for you, Dr. Amal.
Yes.
Is it recommended to change the examination areas in outpatient clinics between patients? And if so, for how long the room cannot be used again? 15 minutes?
Please, Dr. Hiba, again.
Is it recommended to change the examination areas in outpatient clinics between patients? Is it recommended to change the examination areas in outpatient clinics between patients?
Change the examination, not keep a space, keep a time between the patients for cleaning and disinfections, and just the same place. After each patient, we clean and disinfect the place, every place, every wall, every point the patient touched, we can clean it and disinfect it. Then again, reuse the same space, not change the space between the patients. Just clean and disinfect between the patients.
Okay. Thank you, Dr. Amal. Dr. Nagwa, nationally, we are going to follow herd immunity. What about it?
I believe we are following this theory because we never totally locked down. And since the very beginning, we have been exposed to whether infected or, between brackets, carriers, because I believe carriers in virology do not exist. What exists are people having minimal symptoms that passed unnoticed. And so they are shedding the virus to others while they have been taking the infection with minimal symptoms that they couldn't even remember. So we have been all exposed at a certain time before all the population wore the mask compulsory. So a big proportion of the population have been taking the infection. But there is something confusing about this type of infection, about the immunity. And so far, we are not sure if the immunity would last even for the season or not, because there have been explained or written in many studies, but so far they are not controlled studies, they are observational. That the immunity regarding COVID-19 is like 3 months. And also the behavior of the virus with the immune system is very confusing again. Is it a pro-inflammatory process, or it stimulates the immune system to produce antibodies, or both, and which of which would overcome? And when the disease is shown up, why it is sometimes in the lung, and why in other patients it is extrapulmonary. So I believe we have to wait till the pandemic finish, and then we start to do good structured controlled studies, and to understand well what is the behavior of this virus, and do we have many strains? Do our population in Egypt being exposed to more than one strain of SARS-CoV-2? All these questions are in our head, and so far we are discussing just together what's going on. But so far we have to wait till we have proper results from controlled studies. But again, to answer your question, I believe we went through this herd immunity theory.
So another part of the question, is it the viral load or variants that are contributed to the fatality-related COVID-19 among healthcare workers?
I can tell that the viral load is essential, but sometimes with a virulent microorganism, whether virus or bacteria or whatever, sometimes with a mild viral load, you can have the disease. So far, we don't know. Myself, my opinion, I don't know if it is dependent mainly on the viral load, or again, we have different variants or different strains. But I know well that there are so many studies going on in Egypt right now to answer this question.
Thank you, Dr. Nagwa. Dr. Amal,
Yes.
what is the maximum time we can use surgical mask?
At the beginning of the crisis, we started with wearing the surgical mask for 2 hours. Every 2 hours, we changed surgical mask. In certain places where the ventilation is not good, follow these instructions. In other places where there is good ventilations, we extend the use of the surgical mask for 4 hours. This is our policy from the beginning of the crisis. As the time go and our resources starting to be decreased, starting to prolong the time of the mask to 6 hours for good ventilated area and 4 hours in less ventilated areas. But according to standards, it must be worked for 2 hours or when it became wet or damaged, tear. But in our situations for the preserving of the resources, we wearing the mask. Our instructs our healthcare workers to continue to wearing the mask up to 6 hours.
Thank you, Dr. Amal. Dr. Nagwa, how to clean money papers and coins?
And why to clean them? Why to clean them?
I believe that they are transmitting infection.
No, wait, just a minute. Let's agree that SARS-CoV-2 is mainly transmitted via droplet, okay? And if some of the droplets are contaminating surfaces and I'm touching this surface, whether the surface of money or the surface of a table, the important is to have my hands free from contamination before using them. So don't bother yourself with decontaminating the bags of the supermarket, the stroller of the supermarket, the money, everything, but take care to wash your hands or to decontaminate them with alcohol-based 70% alcohol hand product before using your hands, because you are going to contaminate yourself whenever you are going to touch your eyes, your nose, or mouth, okay? We don't need to decontaminate the money.
So another question for you, Dr. Nagwa. When should a person go for lab investigations? If he only develops symptoms or even when there is no symptoms?
Sure.
But there is a history of exposure to COVID-19 patients.
We have been passed through so many stages during this travel of COVID-19 since at the very beginning. And at a certain time, we had to investigate either or both the patient and the contacts of the patients, okay? Nowadays, it's different. Sure, we have to investigate anybody showing the symptoms, okay? But we have to bear in mind that in 35% of cases, we can have a false negative result, even with PCR. So for the patient showing symptoms, it's important to investigate. For contacts, we have to wait for the appearance of symptoms. Why to rush?
Thank you, Dr.
Are we going to give prophylaxis?
Another question for you, Dr. Nagwa. Kindly advise concerning the sport training weekly for our sons and daughters. Could we go on or postpone them recently? And what about the swimming pools? And do we expect a second worse attack next month?
I will answer the last part of the question first, concerning the second wave. The second wave occurs in one of two conditions. The first one, if in the countries where we did a strict and total lockdown. So a big proportion of the population have been protected from being exposed. And whenever we release the measures and we release everybody to go, and there is still the source of infection, we start another wave, which is not the case for Egypt, for our country. And the second possibility, if we have a new strain or a new version of the virus. So it's considered like we are repeating the outbreak from the beginning. So these are the two conditions to have a second wave. I hope we will not have a second strain or a new strain of the virus. And again, we have never been locked down totally. So we We were always there together, except for the period when we started to wear the mask for all the population. Regarding the sports, the gym clubs, the swimming pools, the problem here is the gathering, the crowding. If we can, by the way, the gym courses have been switched to online courses. So take the benefit of this and apply for online gym courses. For the swimming pools, if you can guarantee that the place will not be overcrowded, no problem to go. No problem to go, okay?
Thank you, Dr. Nagwa. Dr. Amal,
Yes.
could a single surgical mask be used only for praying in the mosque during the whole week? And if it's possible, how to save it at home?
Save the surgical mask at home.
Could a single surgical mask
Yes.
be used only for praying in the mosque during the whole week?
Yes.
Is it possible to use a
Yes.
single
Yes.
surgical mask for the whole
Yes,
week?
we can do it. We can do it, but we can wear it safely and remove it safely. Like we catch it from the tie and not from the front of the mask. Tied it on our face, covering the nose, mouth, and after the chin. And when we remove it, kindly from the ties, not from the front, then put it in any clean container, whatever pocket, any container clean and leave it. But every time we wear it, must check for being not tear, there is no tear or damage or being wet. We can see.
And you can save it at home the same way, right?
Yeah.
Okay, thank you, Dr. Amal. Dr. Nagwa, our last question. What do you think the causes behind what we can see now, coronavirus carrier communicating with the family, for example, from four members, and one of them affected, but others are not even develop mild symptoms, although they are exposed to the same degree?
Nobody can tell. Nobody can tell. This is the confusing issue of this novel corona. I don't know why for one person, like you asked the question right now, for people exposed in the same time to the same source, and one developed the disease and others mild symptoms, and the two have been fine. So we don't know. And again, with the children, I was waiting, and thank God, touching wood. I was waiting for a disaster or the crisis with the children with cancer. But again, we have minimal cases coming with the COVID-19, and they got the infection from their parents at home. And again, they responded very well to treatment.
So we have another question related to the answer, to your answer right now, Dr. Nagwa. How can we protect cancer patients from coronavirus? And what's the protocol for cancer patients who were infected by coronavirus?
The protocol of management is not mine, because we have a team for managing, investigating, and treating all cases, whether healthcare workers in the adult intensive care unit, which is a separate unit outside the main hospital building, or for the children. They are managed by pediatric oncology or infectious disease doctors. But in our hospital, we are always working on prevention rather than control. So we are applying all the time the standard precautions and the transmission-based precautions, of course, the isolation measures. We have dedicated rooms for isolation with negative pressure and empty room for the proper donning and doffing of PPEs. So we are used to follow these isolation measures, and we have another nightmare for the children called measles. Measles for cancer children is fatal. So we are used to work with these conditions. What was challenging in this corona or the COVID-19 was with the healthcare workers, because they were very panicked with the disease, especially if we see the cases that were affected during May specifically and early in June. Many cases were very severe, and the strain at that time was lethal. We had so many deaths due to this infection. So being a clinician, for sure, I will be panicked. Although we have been working, as I shown in my presentation, since early March, and we have been focusing on education, awareness, assessment of knowledge. So we started very early, and we started very early to let people feel safe in the hospital, to give them the masks, the PPEs, provided we hold the release of the PPEs during February. Everybody were asking to put on the mask everywhere in the hospital. We said it is not the time, because at that time we didn't have this spread of the infection, we didn't have the community spread. But once we started to have many cases around, we started to put the mask for everyone entering the hospital. And lately we put this policy of tolerance to make everybody feeling safe in the hospital environment, and to take also the home message to continue what we are doing in the hospital while in the they are going back home, or even during their stay at home with their families. So we did a lot. We did a lot for the healthcare workers, for our children, but as I said, what we were doing was something for us more or less regular, because we are facing serious infections for these children.
Thank you, Professor Nagwa, and thank you, Professor Amal, for such informative and interesting session. For our esteemed attendees, thank you for joining our webinar. We hope you enjoyed it, and kindly stay tuned and follow our webinar series in our Facebook page, Executive Education page, or website, and kindly check our healthcare programs, including the hospital management program and the healthcare quality program. You are most welcome always, and please stay tuned for our upcoming webinars. Thank you.
Thank you very much, and please stay safe. Thank you, Dr. Amal, for joining.
Thank you.
Bye.
Bye.
Bye.